next is Dr. Anahita SHROFF.
Good morning. So all of us as ophthalmologists are trained to recognize bitemporal hemianopia in all pituitary tumors. But what if the fields are different? Today, me, Dr. Anahita SHROFF, am going to take you on a junctional journey. So I'm going to present a unique case of a pituitary tumor which presented with an atypical junctional scotoma. Our patient, a 64-year-old male, presented with painless gradual loss of vision in the right eye since 1 year. On examination, he had an early cataract in both the eyes with a grade 3 relative afferent pupillary defect and a pale disc in the right eye. There were no systemic indications or no trauma to suggest the pale disc. So we went ahead with the MRI. On the MRI, we saw an iso-intense lesion in the sella suprasellar region compressing the right optic nerve at the anterior junction of the chiasma. The same lesion can be seen in the T2 weighted coronal section and the T1 weighted sagittal section displayed here. The differential was consistent with pituitary adenoma. So obviously we were expecting pituitary is bitemporal hemianopia, but that was not the case. To our surprise, the fields in this patient were very different from what we had expected to see. There was generalized depression in the right eye and superiotemporal depressed points in the left eye. We referred the patient to the neurosurgeon, and after successful surgical excision, even though the pallor persisted, he improved symptomatically as evidenced by the improvement in HFA and the vision, and with his last visit to us, his vision was improving to 6.6. So what is the underlying secret in this case? It is the knee of von Willebrand. The inferonasal fibers of the contralateral eye loop at the affected optic nerve before crossing at the chiasma. So this is given by Dr. Willebrand, where you can see that these fibers loop around and then they are crossing at the chiasm. So any lesion that would compress this area would cause what we call a junctional scotoma, which involves superior temporal defect in the contralateral eye and a central scotoma or a generalized depression of the compressed optic nerve of the affected eye. So the eye does not see what the mind does not know. We need to recognize the pattern and order urgent imaging and endocrine workup before vision loss becomes irreversible. The treatment for pituitary tumor is surgery, we all know that. But identifying junctional scotoma will help us localizing the lesion more accurately and help the neurosurgeon in planning adequate surgical debulking surgery, as well as we'll know what improvement in the vision to expect post the decompression. So all that glitters is not gold, and all pituitary tumors are not bitemporal defects. Know the anatomy or the diagnosis might fool you. It is important to correlate all the pituitary tumors, the imaging and the fields to come to an adequate conclusion and improve patient care. Thank you.
Thank you, Dr. Anahita. A very important point that you need to actually be aware of all the various positions the pituitary has in relationship with the chiasma, so that the variations in the field effects, and which can be many. So yes, it's an interesting thing to talk about. Of course, uh, these localizations were extremely important before we had very good investigative modalities, but still it's very important to be able to localize, because you need to direct the view of the radiologist as to where you want the lesion, where and what kind of lesion. And despite we think that all MRIs are the same, you will be uh, just kind of overtaken by the number of now changes and developments that have come in the MRI. So now you have to actually very specifically write the kind of imaging you want, or else localize the site and the tentative lesion that you are thinking, so that the appropriate investigation can be done. Shailaja, any comments?
I was just asking that was the fields done before the MRI or after the
No, ma'am,
MRI
we did
as it
the
is?
MRI first. Since there was pallor, we wanted to know if there's something going on inside.
So if you do the MRI first, then you lose the localizing capacity or the
Yes,
function of
ma'am.
the
We
visual
did the
fields.
fields for
So
documentation. We were expecting a bitemporal, but it came out like this. So we thought it was something interesting that is what.
yeah, but it could have been done the other way. That's usually the case because bilateral temporal pallus could be because of, in a
was
patient could be
unilateral,
because of
ma'am, only right.
unilateral also, it could be because of any other pathology rather than an ICSOL. So whether to image for an ICSL or not depends upon the fields. So first you would do a fields, and you can do a fields with a 660 vision with a stimulus size 5, and get you could have got this information even before, and use it exactly as Dr. Rohit has mentioned.
Thank you.
Thank you.